Great. So welcome. The last thing we did yesterday was IBD, and Nightwing really summarized IBD for us. We thank him for that. So today we're going to start from number 194. Number 194. So, as always, I encourage all of you to be active in the discussion. Feel free to unmute whenever you feel you have a point to add, or to write on the chat box. We'll read out whatever is written on the chat box. Also on the WhatsApp group, you can send your contribution there. We'll also read out what is on the WhatsApp group and what is on the chat. Great. So starting with number 194, question asks, all of the following are causes of constipation except. All of the following are causes of constipation except use of NSAIDs, laxative abuse, pregnancy, use of anticholinergic medications. So all of the following choices are causes of constipation except. Which one is not a cause of constipation? Is it use of NSAIDs or NSAIDs, laxative abuse, pregnancy, or use of anticholinergic? I
think it's use of NSAIDs because we know that I think anticholinergics are some of the medications indicated which can cause constipation. That's one. And then and then two, we have pregnancy. For pregnancy, we know that about 50% of women who are usually pregnant usually experience constipation, and that's due to the affected reabsorption of water in the colon, problems with the iron supplements, and an increased progesterone level, which leads to slow digestion. So that can lead to constipation. And then also, laxative abuse is usually associated with those miscellaneous secondary causes of constipation. So the answer here is NSAIDs.
NSAIDs. Great. Thank you for the explanation. Yeah. So just as a quick question, how would you treat constipation? Both non-pharmacological, then pharmacological. How would you treat constipation?
For treating, I think first of all, it depends on the patient. Now, let's say, for example, you have a patient who has been abusing laxatives. Obviously, you'd want to try something else other than, So for pharmacologically, I know we have our bulk producers, and those ones basically just swell the interstitial fluid, forming a gel which promotes peristalsis. And then we have our hyperosmotic, or I can give examples if you want. I think our bulk producers, we have the naturally derived, I think psyllium, something like that. Psyllium, we have our semi-synthetic, which is polycarbophil, and we have our synthetic, which is methyl cellulose. And then for hyperosmotic, obviously hyperosmotic, it just calls water into the colon. There we have glycerin, sorbitol, and lactulose, I think. Yeah, and then we have our lubricants where we have our mineral oil, just as it states, it just coats the it coats the stool to promote expulsion by having a film, a sort of oily film. And then lastly, we can also use stimulant laxatives such as bisacodyl. But in terms of like non-pharmacological, we'll ensure dietary and general modifications accompany the use of laxatives. So we can increase dietary fibers. So make sure the patient is having high fiber foods, avoid low fiber foods, ensure adequate fluid intake, ensure the patient is engaging in exercise. Yeah, basically the exercise is usually tone the muscles in the abdomen. What else can I remember? Yeah, that's as far as I can go. That's what I remember. Please.
Great. I think you extensively covered the treatment of constipation, right? Especially fiber for non-pharmacological fiber and water. Then for pharmacological, those agents as you have described. So, see, Dr. Fatma sent something on the group on the causes, the various causes of constipation. You can just have a look at it. Perhaps I'll just mention a few that have been written, especially on the drugs. The opioids, opioids, TCAs because of the anticholinergic activity, diuretics because the water depletion, iron and calcium supplements. So those are the most implicated drugs in causing constipation. Opioids, TCAs, diuretics, iron, and calcium supplements. Yeah. The other causes you'll see from the diagram there. So for number 194, choice A, just to read out what is on the chat box, is 2 is saying for non-pharmacological, you drink more fluids and you eat more high fiber foods. So number 194, choice A, NSAIDs are not associated with constipation. Moving on to number 195. All of the following statements are correct regarding heart conduction system. Go on, Lydia, go on.
Excuse, can I ask a question?
Yeah.
So pregnancy is associated with both constipation and emesis. Okay, that's all.
Okay, so number 195. Has someone answered her? I think my internet was shaky for a bit, so I'm not sure if she's been answered. Willie.
No, she's good. I think she's
good.
Yeah, she's
So number 195, all the statements are correct regarding the heart conduction system, except. So regarding the heart conduction system, except. Number 1, the AV nodes prevent the conduction of excess atrial beats. Choice B, excessive vagal stimulation results in tachycardia. Choice C, sinoatrial node controls the heart rhythm. And choice D, the activity of the heart is controlled by both sympathetic and parasympathetic nervous system. So all statements are true except from choice A to choice D, which statement is not true? Is it the AV node prevents conduction of excess atrial beats? Excessive vagal stimulation results in tachycardia. Sinoatrial node controls the heart rhythm, and the activity of the heart is controlled by both parasympathetic and sympathetic. Dr. Hiral is saying excessive vagal stimulation results in tachycardia is the false statement. She goes ahead to say that excessive vagal stimulation would result in bradycardia. Leo, please feel free to unmute. You had raised your hand. Okay. Anyone with anything to vagal stimulation in the is parasympathetic nervous system, so can cause bradycardia or normal heart rhythm. Yeah. Anyone else with something to add on the Hans is saying that vagal stimulation is associated with parasympathetic effects. So on the heart conduction system, are we good? Are we okay? Sinuatrial node, how the current flows from the sinuatrial node all the way down to the Purkinje fibers. Are we okay? We want a quick overview?
No, tell us.
Overview, please.
A quick overview. And I'm seeing our cardiologist, Dr. Hiral, is here. So, Dr. Hiral, just a quick overview on the heart conduction, kindly.
Okay. So the pacemaker SA node, that's where everything starts. So once the SA node is excited, it sends signals to the AV node. These are both in the atrium. So I think the SA node is the one that sends. Is it the SA node or the AV node that sends signals to both the atriums?
Yeah, it's the SA.
SA.
Atria,
Yeah. Yeah, and then the AV node now sends signals through the bundle of His to the Purkinje fibers. So that's now the ventricles. Okay, so SA node, that's where that's the normal pacemaker, and that's where excitability is.
Jambi is asking if you can please start again.
Yeah, that's what I'm doing. Yeah, so the SA node now, how excitability is, because the SA node is it has this sodium leaky channel, so that's how they can get excited by themselves. And yeah, so the SA node sends signals to the AV node and both the atriums, because I think the SA node is in the right ventricle.
Right atria.
Atria, yeah, right atrium, and then so it sends signals throughout the right atrium and the left atrium, and then also to the AV node. Then from the AV node, it goes to the bundle of His and the Purkinje fibers, which now will depolarize the ventricles. Then the cycle starts again with the SA node.
Perfect. Thank you for that. Yeah, so yesterday we looked at the PQRS T, that whole wave, and today we've appreciated the conduction. Dr. Stanley has also sent the same on the group that describes what Dr. Hiral has just said, from the SA to the AV to the bundle of His down to the Purkinje fibers, which will depolarize our ventricles. Moving on, unless someone has something to add, as always, feel free to unmute, feel free to type whatever little contribution you may have on the chat box. We'll read it out. Every little thing counts. Everything counts. So number 196, all of the following are peripheral causes of nausea and vomiting. All of the following are peripheral causes of nausea and vomiting, except increased intracranial pressure, motion sickness, delayed gastric emptying, gastric mucosal irritation. So all of the following are peripheral causes of nausea and vomiting, except. So which one is not a peripheral cause of nausea and vomiting among the choices given? Is it motion sickness, intracranial pressure? Yeah, everyone is shouting on the chat box. Increased intracranial pressure is not a peripheral cause. But all the others, motion sickness, delayed gastric emptying, gastric mucosal irritation, those are peripheral causes of nausea and vomiting. So quickly, again, if someone would give us a quick overview of management of nausea and vomiting in pregnancy, management of morning sickness. No, that's a major thing. And it's something that is easily managed in the community pharmacies. So our community pharmacists, please, how do we manage nausea and vomiting in pregnancy? Please unmute or just send it on the chat box, we'll read it out. So while perhaps if someone is typing, I'll just read out what Dr. Shrina has sent on the group about the causes of vomiting. We have the anxiety and raised intracranial pressure. This pathway is through the cerebral cortex. Now, of course, that is the CNS, the central nervous system, stimulating the vomiting center, leading to that nausea and vomiting. And for the peripheral causes, we can have gastric stasis, radiation colitis, or chemo, which will stimulate the GI tract receptors such as 5-HT3, 5-HT4, and D2 receptors, which will ascend all the way back to the vomiting center, stimulating nausea and vomiting. Drugs and hypercalcemia will stimulate the chemoreceptor trigger zone through the various receptors, leading to the same. And finally, vestibular neuritis, whereby we are having vestibular input through the muscarinic acetylcholine receptors and the histamine receptors, leading to the nausea and vomiting. So based on this, we can appreciate why we can see the various receptors found in the vomiting center. Again, the vomiting center is found in the medulla, right? The medulla forms part of the brainstem. So we can see the various receptors. We have the muscarinic receptors, we have the H1, we have the 5-HT2, the murin, and the neurocephalin and K1. Don't remember exactly what they were. But based on this and even some receptors listed there, the GI tract receptors, we can appreciate why drugs such as ondansetron, which are 5-HT3 antagonists, how they work to prevent vomiting, nausea and vomiting. So the potent antihistamines or the first generation antihistamines through the blockade of the H1 receptor in the vomiting center, and also hyoscine butyl bromide for the treatment of motion sickness. We can see in the vestibular input, blocking of these muscarinic receptors will inhibit the activation of the vomiting center. So back to the, great. Let me just read out what is on the chat box. Patient is telling us management of nausea and vomiting. This is in pregnancy. The first line, we have the doxylamine pyridoxine combination. They usually come in a combination. If that doesn't work, metoclopramide, domperidone can also be added. Thomas and Sunshine are agreeing on doxylamine and pyridoxine combination as being the first line. Usually the brand name Hamimti has given us, such as Pregnidoxin or Nosic, Pregsmile. Also, ondansetron can be used for not motion sickness, for this morning sickness. Hiral is also adding that substance P binds to the NK1 receptor. Great. So first line management in terms of pharmacology is this doxylamine pyridoxine combination, commonly known as Nosic, the common brand on the market, right? So number 196, we can go with choice A. Unless someone has something to add or a question, something you'd like.
Even when we were at the clinic doing attachment, it was interesting to see whenever we'd run out of Placid or metoclopramide, we'd give DOM. Okay, initially there were people who were giving ondansetron, but then I realized that MOAs are different because ondansetron is a serotonin 5-HT3, while metoclopramide is a D2 antagonist. So we would give either metoclopramide or domperidone as the alternative, because they both have a similar MOA in terms of blocking the D2 antagonist, being D2 antagonist.
Great. Thank you. And Pap, what's the difference? There's someone.
Yeah, I have a question. I'm saying that even you can give dexamethasone, which is a steroid. What's the role of a steroid in nausea and vomiting?
Yeah, an interesting question. What's the role of a steroid such as dexamethasone for nausea and vomiting?
I'm not too sure, but I think dexamethasone it causes down regulation of this 5-HT3. This serotonin receptors that cause nausea and vomiting.
Yeah, exactly. Or I was to say the exact same thing. It causes that down regulation and reduced synthesis of those 5-HT3 receptors. So less 5-HT3 receptors, less vomiting. Because we see it especially being used for chemotherapy. Yeah.
Maybe. Dina, go on. Okay.
Pardon?
Maybe to add on, since you talked about the motion sickness, morning sickness, there's the hyperemesis gravidarum, which is the severe vomiting in pregnancy that doesn't even stop after 13 weeks or like whatever weeks. Like it's persistent and goes on, unlike the morning sickness that stays for a long time. So for the treatment of that, we give IV fluids because there is severe dehydration. So we will give IV fluids to restore hydration, electrolytes, vitamins, and nutrients that are lost due to the severe vomiting that occurs. And then we give nasogastric tube feeding that restores nutrients through a tube passing through the nose and into the stomach. And for treatment, we use IV ondansetron. Yeah, I would say the differences with the group.
I think, yeah, and she's highlighted something very important, that morning sickness usually ends there around the 13th week to 14th week of pregnancy. Morning sickness, typically for most pregnant ladies, it should have ended by then. And lastly, I think on morning sickness, the term morning sickness should not trick you that nausea and vomiting only happens in the morning. It happens at any time. So it's not only in the morning. Then Willie just brought out something that I'd like to highlight: the difference between domperidone and metoclopramide. Despite both of them being D2 antagonists, there's a key difference between them. What is it? Anyone? between domperidone and metoclopramide. They are both D2 antagonists, but one is unique or they are different in a certain way. Anyone?
I think domperidone, I think it doesn't cross the blood-brain barrier. Is that what?
Yeah, perfect. Yeah. Domperidone doesn't cross the BBB. Yeah. So it would not lead to the extrapyramidal symptoms that we see with metoclopramide, long-term administration of metoclopramide. Yeah.
Something else I also saw in a past paper is to do with respiratory metabolic alkalosis, because when you have vomiting, you're likely to lose your hydrogen ions present in the gut. So that's also likely to cause metabolic alkalosis within the body, because you've lost a lot of hydrogen ions.
Great. So that pH imbalance can also lead to the same.
Just to add on domperidone and metoclopramide. It's not that domperidone doesn't cross per se, but it does cross to some degree, but to a lesser extent. That's why it causes those CNS side effects.
Great. So it has a lower propensity compared to metoclopramide. Thank you for that. Anyone else with something to add before we move to the next and go to the chat box? Not checked. Okay. She's been answered. So moving on swiftly to number 197. Question asked, which one of the following is not necessarily included in the informed consent form? Which one of the following is not necessarily included in the informed consent form? 2 is telling us the sampling procedure is not typically or necessarily included. The purpose of the research is, I think, especially for those of you who have done research that involved interviewing people, the purpose of the research has to be shared. Any benefits or lack of them has to be shared, and you have to guarantee the participant of anonymity and confidentiality. That's I think that's a straightforward question. Don't need to dwell much. Number 198, because socioeconomic status is difficult to quantify, we commonly use all of the following substitute measures except, because socioeconomic status is difficult to quantify. We commonly use all of the following substitute measures except educational achievement, family income, occupation, or social standing. So which term don't we use as a substitute to represent socioeconomic status? Is it occupation, family income, or educational achievement? The chat box, I'm saying educational achievement. Educational achievement. Anyone else with a different opinion?
Social standing.
Social standing. So there's educational achievement and there's social standing. Let's see. Hiral and DC there for social standing. Corazon is also for educational achievement. Since most people are going with social standing, perhaps Sam, if you're in a position to unmute, will you explain why educational achievements? Or what's your reasoning behind that?
Okay, can I just explain why not A? To me, educational achievement is like education level. Did you reach the primary level, secondary level, university level? So that's a socioeconomic status which can be used in a study. And social standing, I don't know what it, I don't even know.
Okay, actually, it supports educational achievement because I feel like educational achievement basically refers to what level or to what degree have you studied and what certificates do you have. And I feel like you can actually achieve education merit through scholarships and sponsorships. And you could also well-off family, but not be able to get to those levels because of the merit related education system. So basically you get to Form 4 and you're not able to proceed to the next level because you didn't get the necessary grades. So you end up doing maybe something like a certificate, which actually denotes the educational achievement. But someone else might be from a low background, then end up getting a scholarship and they performed well and they happen to get really good academic merits. So that doesn't it cannot really clarify the personal background of a particular person. But for social standing, I assume it's the same as or almost similar to what we call the status. Are you from the middle class, the lower class, or the upper class? So that can be used to in terms of describing the social economic status of a particular person, in my opinion.
How would you quantify like social standing? If you're saying educational achievement, then for social standing, how do you rank someone?
As
Social
in,
standing for me, I don't know. Social standing me, are you respected by society or not? Like, see, that's all it matters. Like, how are people viewing you wherever you are? You could be with educational achievement, or you could even be rich socioeconomically. You could be high and respected or not. Like, it really doesn't matter. Hizi zingine zina affect social economic status directly. Knowing that you're able, if you have maybe tertiary education, you're likely to be in middle or higher status socioeconomically. Family income, if you're born rich, you're going to be rich. Occupation, if you're working like a casual worker, you're likely to be a low or a middle.
Yeah, I think
Social
even
economic, yes, you're likely to have a higher economic status than everyone else, or a lower one. So social standing, no, it cannot be the answer. Like, no one cares if you're respected or not. Like, really, no one cares.
But how will you quantify the social standing?
I think for
Like, what's the
educational
cutoff
achievement,
between a middle class, a lower class, and are you looking at the wage bill? What are you looking particularly
I think
for you
I
to say
think
the over high social class or whatever class?
I think before, like even when we say educational achievement, I think from a health perspective, it's very important because now we expect that the kids who are in class 4, class 5 understand the importance of washing their hands. Like that can be used as a socioeconomic status because these children themselves understand from a health perspective the importance of the little skills that we teach. I'm not very sure about social standing.
okay, so I feel like you guys, someone was trying to describe social standing, and I think they gave the wrong definition because the definition I'm getting of social standing The saying social standing refers to a person's status or social class in society, which is based on factors such as wealth, education, occupation, family background, etc. So basically, we already have wealth being a factor in social standing. But in education, wealth isn't a factor because so many people have actually come from very poor backgrounds, but they have very high academic standings. And I don't think about the social standing.
Okay, may I have a question? Is there like a relationship between someone's educational achievements or education level and their socioeconomic status?
Yes.
Of course.
Then if there is, see, basi, then that can be used as a measure of socioeconomic status, because then we most of the time we are likely to assume that if someone has a certain educational achievement, then they are more likely to even maybe get a better job or a better paying job and such. So then the higher your educational achievement, it's most likely going to translate to better income. And then I think it will affect your socioeconomic status or something. I don't know.
What is the relationship?
I think we are assuming that high educational achievement means good occupation. You can have a PhD and all that, but still you've not gotten a job and everything. So we are not.
Hello, can I just give my view?
Yeah,
I
go
think
ahead.
for this, you're just overthinking most of the studies. When you go under the socioeconomic status, you'll find that education level is one of the key factor which is used to assess the socioeconomic status of someone, and the family's income is one of them, and the occupation. I've rarely seen social standing being one of the factor being used. So I think we're just overthinking. We should just go straight to what we have and go on with the discussion. I don't know. If you most of the studies, under socioeconomic status, you find that education level is mostly used as the key factor for the socioeconomic status.
Okay, just
you
to
find
remove
questions like Nini, have you gone to education level? Is it at primary level, at secondary level, or Nini at university level? Yeah. So I think the correct choice is social standing.
And what is social standing?
Lydia has really brought out the question being asked here. It's not a sociology question, it's related to research. So if it's related to research, we do know education comes under socioeconomic status, educational level, degree, diploma, such things. And so we can we agree and we move, because I don't think we should spend much time in such a question.
Yes.
Yeah, more scientific.
Thank you.
Yeah. So democracy says choice D. So we'll go with choice D. So moving on to number 199, the time course of a disease outbreak is usually displayed as a dash, and the time course of a disease outbreak is usually displayed as a secular trend, seasonal trend, epidemic curve, or endemic curve. The time course of a disease outbreak.
The clues in outbreak. So epidemic. Secular trend is usually for I'd say graphs over long periods of time, even years sometimes. Seasonal trend, as in the name seasonal, and then endemic is not an outbreak. An endemic disease is not an outbreak. So
number 199, I'm assuming we're all in agreement there. It's just an epidemic curve because it's a disease outbreak. Yeah. Moving to number 200, allergic reactions to penicillin by some patient is classified as a dash hypersensitivity. So an allergic reaction to penicillin, what what class of hypersensitivity reaction is it? Is it type 1, type 2, type 3, or type 4?
It's type 2, because that's where we get our antibody-mediated hypersensitivity reaction through IgG and IgM. So that's where we get our antibodies to now fight the foreign substances or the penicillin in this specific case.
So Dr. Njoroge says type 2. Anyone else with a different opinion? Dr. Anita says type 1. And also we are having, person is requesting on the same lines if we can do a brief overview of hypersensitivity reactions. Yeah, I'm seeing most people on the chat box are saying hypersensitivity. It's a type 1 hypersensitivity reaction. It's a type 1 hypersensitivity reaction. All right.
Okay, guys.
Mm-hmm.
So I think most people, they're saying type 1 because it's IgE mediated. So penicillins, one of their metabolites is penicilloic acid. So that acts as a heptin and it causes allergies. It causes an anaphylactic shock, which is type 1 mediated hypersensitivity. So if there is IgE mediated hypersensitivity, that means it's type 1. So this something else I wanted to add is for when you are administering penicillin, you should always have adrenaline next to your epinephrine because most patients have allergy to penicillin, right? So once you inject the insulin, you give a small dose of subcutaneous penicillin, sorry, not insulin, penicillin. And then if you see there's an edema or rash, that means there's penicillin allergy. So you, like if the patient has severe anaphylactic shock, now you give epinephrine. So in cases of penicillin allergy, the most substitute we use is erythromycin.
Perfect. So yeah, she's described to us that it is actually a type 1 hypersensitivity reaction because it's IgE mediated. Also, if you're administering penicillin, you should have your adrenaline nearby in case of an anaphylactic, anaphylactic shock. Also, she's talked about, what was that thing? Okay. Oh yeah, the metabolite that it's the allergic reaction is that metabolite penicilloic acid that that acts as a hapten. Is it an hapten? Penicilloic acid, yeah.
Yes, haptens.
Then kindly, if you have that slide, I remember that slide was somewhere in yeah, I found it. That penicillins and their breakdown product will act as haptens. We know, yeah, where haptens will combine with a protein. Once they do that, they lead to that anaphylactic reaction. So we can all agree that for that, it's been duly explained that it is a type 1 hypersensitivity reaction, IgA. Then I see Dr. Sam has said that he finally agrees that choice D is the answer for number 198. Yeah, so I think we are all on board. And because Corazon requested that we do a quick overview of the types of hypersensitivity reaction, I'll just go through them as shared on the WhatsApp group. So for the hypersensitivity reactions, we have type 1s, 2, type 4, type 1, type 2, type 3, and type 4. For type 1, this is where we have our allergic reaction, and the IgE is the implicated antibody that mediates allergic reaction. So IgE, essentially, the pathophysiology just deals with IgE will bind to the mast cells, activate them. or cause that degranulation reaction, the mast cells will produce the histamine, the leukotrienes, and we know this histamine will cause that bronchoconstriction and such, leading to these things such as asthma, anaphylaxis. Yeah. So examples of type 1 hypersensitivity reaction, anything to do with an allergy, food allergies, seasonal allergies, anaphylaxis, asthma, rhinitis, such things. When we go to type 2, so type 2 reactions, type 2 hypersensitivity, also known as cytotoxic mediated hypersensitivity reaction, we are having IgM and IgD as the implicated antibodies. And in this case, these antibodies will bind to surface antigens on the patient's own cells, right? It will respond to a surface antigen. So in this case, a very typical example is usually the hemolytic anemia or the hemolytic disease of newborn, whereby the mother's antibodies attack the baby's red blood cells. The other examples are the good pasture syndrome. Yeah. Moving on to type 3, this is immune complex mediated. The implicated antibody here we are having is IgG. The implicated antibody is IgG. And this one relates to, we know once the antibody and the antigen form that immune complex, that immune complex is supposed to be cleared by stuff like the macrophages. But in this case, this immune complex is not cleared and it goes to be deposited elsewhere in the body. If it's deposited in the kidney, it activates, it brings about an inflammatory reaction in the kidney, leading to nephritis. If it's deposited in the joints, it can lead to arthritis. And in this case, this is where we have our rheumatoid arthritis, also as an example of a type 3, vasculitis and serum sickness. Those are examples of type 3 hypersensitivity reactions. Then finally, we have type 4, which is also called the delayed hypersensitivity reaction. And this is unique in that it is mediated by T cells. All the others are mediated by antibodies. But type 4 is unique because it's mediated by T cells, also known as a cell-mediated hypersensitivity reaction. So the pathophysiology just kind of similar to what we were saying, only that it's the T cells which will recognize an antigen complex and activate the macrophages. The macrophages secrete the cytokines and lead into a inflammatory reaction around a certain place. So this is why we have our Steven-Johnson syndrome, our contact dermatitis, celiac disease, among others. So encourage also on the same, if guys can add the examples of the other types of hypersensitivity reactions on the chat box or as a reply to that image, it will really help all of us. So you reply to that image on types of hypersensitivity reaction with examples of type 1, type 2, type 3, type 4 that have not been listed on that photo. It would really be a big boost. And then let me just read out what I may. So Han says it's IG mediated, as we've said. The drugs involved in type 1 reactions are penicillin, cephalosporin, and neuromuscular blocking agents. Type 2, we have the rheumatic heart disease. Type 3, we have the rheumatoid arthritis. So kindly differentiate between the two. Type 2, rheumatic heart disease. Type 3, rheumatoid arthritis. The drugs involved in type 2 are methyl dopa, aminopyrin, and heparin. Intravascular destruction may occur by complement-mediated lysis. Shrina will share the slide. Someone else is adding that although type 1 is the most common for penicillins, note that penicillins also cause type 2 and type 3 hypersensitivity reactions. Although type 1 is most common, it also causes type 2 and type 3. All right. So I guess for this particular question, perhaps the keyword was allergic. Anytime you see allergic, that is just type 1. as we've mentioned.
I would like to add something.
Yeah, go ahead, go ahead.
And then under penicillin, it's good to note that the penicillin are not immunogenic. They only become immunogenic after binding to the proteins in the body. That's when now the penicillin, which is a hapten, a small molecule which is not capable of causing an immune reaction, binds to the proteins. That's when they become immunogenic. That's when they're capable of causing an immune reaction. Yes.
Thank you for that. Thank you for that. So they are not actually immunogenic. They need to bind to a protein, after which now that complex will now be the immunogenic component, right? She's even just defined the term, what are haptens? Haptens, yeah. So moving on to the next question. So which one of the following is true about the hypothalamus? I think we've done this, Shrina. Or rather, we've done this past paper. So while we are scrolling, someone asks, so what type of hypersensitivity reactions do we see with sulfur drugs? Yeah, if it's the Steven-Johnson syndrome occurring, just as said, it will be the type 4 hypersensitivity reactions. Yeah.
Steven-Johnson is type 3. What about TENS?
No, that's type 4. No, I've said Steven-Johnson is type 4.
I think for TENS and SJS, I think they're sort of the same, but the difference is one is acute and
Really?
chronic. Yeah.
I
was saying both of them are type 4, but the only difference is one is acute and the other. Guys, I was wondering, is there any way we can get
Unapotea mzee.
I'm saying, unaweza nisikia? Nasema, the difference between SJS and TENS is one is acute and the other is chronic, but they're sort of the same, so they're both type 4. I was wondering, guys, can we get the board paper, the samples which are on the site? These are all model papers, because I've tried to download them.
Difference ya TENS na nani, whatever. Really, I don't think it's whether it's acute or chronic. Rather the degree, the surface area that's involved.
Oh yeah, okay.
With 10 or more than 30%. With the SDS, it's less than that.
Great. Thank you, Nightwing. Just keep scrolling.
Have we done this?
Yeah, we've done this. Tolerant, one is not of plant. Yeah, we've done this question.
Okay. You let me know when to stop.
Yeah, I will.
This part? Yeah.
Yeah, continue. Yeah, we've done this. Now just go antidote. We've done this. We've also done this. Yeah, I remember.
Yeah.
Yeah, we are great. Let me pause the recording. So number 143, the question asks, concurrent administration of probenecid and piperacillin may cause what? And we went with that answer of prolonged blood concentration of piperacillin, because probenecid will inhibit, or okay, the right term is compete, but let's go with inhibit. It will inhibit the renal excretion of piperacillin, hence hence piperacillin will stay in the system for longer. Have we done this? I don't think now. Perhaps someone can confirm from number 146. Have we covered such a thing? I'm seeing us.
I don't think so.
We did. 7 glyphosate.
But you know that one we were doing it when we were studying pharmacognosy, not as when we were going through the whole paper as we are now.
Oh, okay.
Yeah. So starting from number 146, the question asks, hypertension cannot be exacerbated by oral contraceptives, indomethacin, prednisone, and paracetamol. I think for that, that is just straightforward. It's PCM. Don't need to spend much time there, unless if someone can explain how the other drugs exacerbate hypertension, just briefly, maybe just 2-3 statements. How oral contraceptives, indomethacin, and prednisolone, how can they exacerbate hypertension?
Okay, I'm not sure, but I think steroids, including the prednisolone and the oral contraceptives, they basically enhance water retention because they act as aldosterone, if I'm not wrong. They act on the aldosterone receptors. So they'll enhance water retention and yeah, basically exacerbate hypertension.
Great. What about oral contraceptives?
I was thinking of the same explanation because they're still steps. Unless there's another reason.
Excuse?
Yeah, Edward, go on.
I think it's all about inhibition of prostaglandins. The steroids and the anti-inflammatory, the indomethacin, will inhibit synthesis of prostaglandins, which physiologically enhance process of vasodilation.
Nice. Okay, that's another mechanism through which they can exacerbate hypertension. Yeah, no, prostaglandins are vasodilators.
To be specific, the prostaglandin E2 in the kidney. So the prednisolone, which is a corticosteroid, and indomethacin, which is an NSAIDs, will inhibit the prostaglandin E2 synthesis in the kidney. So it will exacerbate hypertension. So that's the mechanism of action, because the corticosteroids are more of anti-inflammatory than the sodium retaining, the mineral corticoid activity. Yes, so I support her.
Great. So the PGE2 specifically, yeah, and also she's brought about the concept of different steroids have different mineral corticoid activity. So if it's a patient with hypertension, you want to choose the steroid with the least mineral corticoid activity. Just to read out something on the chat box, that oral contraceptives produce changes in the RAS system, particularly a consistent marked increase in the plasma renin substrate concentration, which may be associated with increase in plasma renin activity and aldosterone excretion. So that is reference from Google. But in short, the oral contraceptives, they have some stimulatory activity on the RAS system, leading to fluid retention, which will exacerbate hypertension. So, I hope if someone can find that a table with the common corticosteroids and their different mineralocorticoid activity and share it on the group, it would be really nice so that we can see the most, the steroid having the highest mineralocorticoid activity and the one having the least. Just something to be noted is that different prostaglandins can cause either vasodilation or vasoconstriction. Different prostaglandin can cause either vasodilation or vasoconstriction. So number 147, the question reads, cardiac glycosides are contraindicated in dash. Cardiac glycosides are contraindicated in dash: constrictive pericarditis, dilated cardiomyopathy, cardiac arrhythmias, or congestive heart failure. In which of the following listed conditions would you not give a cardiac glycoside? Dr. Sam, you said you did this question. Hirali just would want a confirmation if digoxin is a positive or a negative inotropic agent. Is digoxin a positive or a negative inotropic agent? And while we are on it, we can also go through cardiac glycosides.
It's a positive.
Yeah. So it's a positive inotropic agent. And perhaps someone can tell us what's the difference between inotropic and chronotropic. You know, those words, they sound similar. What is, when you say it has an inotropic effect and this one has a chronotropic effect, what's the difference?
Inotropic is the force of contraction within the cardiac muscles. And chronotropic is the heart rate, like the number of action potential that can occur per minute time.
Nice. So inotropic deals with the contractility force, and chronotropic deals with the heart rate. So digoxin increases contractility of the heart. And someone else also has added, oh yeah, the third important thing, the dromotropic. Dromotropic, now this one has to do with conduction. So inotropic contractility, chronotropic heart rate, dromotropic conduction. Thank you so much for the addition. So inotropic contractility, chronotropic heart rate, and dromotropic conduction. Now back to the question before we proceed to discuss cardiac glycosides. We can, in which of the following?
Can I just say something? Like someone said, like a mnemonic for the chronotropic, the first three letter is cardiac heart rate from the word chronotropic. So just in case you forget, cardiac heart rate. Yeah.
Nice. That's a beautiful mnemonic to remember. Chronotropic is heart rate. We say the first three letters, cardiac heart rate. Nice. And when we say positive chronotropic, it means it increases. Negative, it decreases. Yeah. So in this case, we are saying digoxin is a positive inotropic, means it increases contractility. Yeah. Mistake is telling us that cardiac glycosides are contraindicated in constrictive pericarditis. So the mnemonic is for the chronotropic specifically, to remember it, is the first three letters, CHR, so cardiac heart rate. So chronotropic has to deal with cardiac heart rate. Yeah, exactly. Thank you for typing it out. So meanwhile, someone can just give us a quick overview of cardiac glycosides. Kindly, just a quick overview of cardiac glycosides. What are they? And then we can also do briefly an overview of the pharmacology of digoxin, because we haven't discussed that despite digoxin being a major drug. I don't know if Stanley is available. He recently covered cardiac glycosides in or anyone. On just a brief overview on cardiac glycosides. What are they? How are they classified? Seen something sent on the group.
Okay, so for cardiac glycosides in terms of pharmacognosy, you have they're classified as two. There's cardenolides, which is digitoxinogen, and there's bufadinolides. Those are the two classes. And yeah, so those are the glycons, which are usually insoluble in water.
Okay. So the cardenolides and the bufadinolides, and our most common cardiac glycoside would fall under the cardenolide, digoxin.
Yes.
Great. Anyone else with something to add on this cardiac glycosides? How, or rather, perhaps the test for cardiac glycosides. I think that's something examinable. Or what tests do we use to detect cardiac glycosides? See on the chat box if there's anything. Nothing on the chat box yet. Yeah, cardiac glycosides.
I can talk about the mechanism of action. They work by inhibiting the sodium potassium ATPase. Thus, they will reduce the pumping out of sodium from the cell. And this in whatever will also lead to affecting the sodium potassium exchanger. So in this case, sodium is not being pumped out, also calcium will end up also accumulating in the cell. That has to change to increase potassium, increase sodium, increase heart contractility.
Nice. Could you kindly just repeat again is what you said?
So basic, is there a sodium, potassium, calcium channel? Okay, maybe not. So,
sodium calcium exchanger.
Yes, so it starts by affecting the sodium potassium ATPase. Yes, ATPase. Once that one is disabled or it's inhibited, it will lead to, ideally the sodium potassium, it helps with exchanging potassium in, sodium out. But once it's inhibited, there's accumulation of sodium in the cell. Now, this will also end up affecting the sodium calcium exchanger, whereby the sodium calcium exchanger works by kicking out calcium. I think it kicks out calcium, yes. Right?
Does it usually, or when you've given digoxin?
Usually.
Oh yeah, it exchanges sodium for calcium.
Yes. But now in this case, we'll have everything. Okay, somebody to explain what I explained the first time. Because I've forgotten what I did the first time.
When you administer the digoxin, you'll block the sodium potassium ATPase pump, which in turn will affect it will cause the sodium to increase in the cell. So in turn, it will affect the sodium calcium pump, which will it will do the opposite. Now it will pump sodium out and calcium in. When you pump calcium in, it will cause the contraction of the cardiac cells.
Great. Thank you for that. So you block the ATPase, sodium accumulates, so the sodium calcium exchanger has to work extra hard to pump sodium out, calcium in. If calcium is inside the body, we know that will help us with the contractility. It will increase the contractility, the force of contraction will increase. Perhaps maybe on side effects, digoxin is, we say it's one of those with a very narrow
mechanism.
On the mechanism.
On the mechanism of action, the digoxin, it increases the force of contractility without increasing oxygen demand. That's something worth noting.
Great. It increases the force of contractility without increasing the oxygen demand. Nice. Thank you for that. Anyone else with something to add on digoxin pharmacology? Let me just read out what has written on the chat.
I've got an information here about pharmacology of cardiac glycosides. And at therapeutic doses, they produce positive inotropic effects and negative chronotropic effects and increased vagal tone of SAN. Also, they inhibit, just as another person said, they inhibit the membrane-bound sodium-potassium activated ATPase, increasing the intracellular sodium concentration, hence reduce calcium transport from cell and facilitate calcium entry. Again, therapeutic use of cardiac glycosides include, they produce myocardial contractility and efficiency. They improve systemic circulation and renal perfusion. And they are also used in congestive heart failure, atrial fibrillation, and atrial flutter, and contraindicated in ventricular arrhythmias. That is, digoxin is contraindicated in ventricular arrhythmias. Thank you.
Thank you so much for the addition. Nice. So just to read out something on the chat box sent by Dr. Jesse. It says that cardiac glycosides possess positive inotropic effects due to inhibition of the sodium-potassium ATPase, which allows calcium to accumulate in myocytes, leading to enhanced contractility. These drugs also possess some antiarrhythmic activities, but will induce arrhythmia at higher dose levels. Then on the group also something, there's an image on what has been sent. On the test for cardiac glycosides. Yes, you can just have a look at it. I'll just list them. There's the legal test, the Lieberman's-Bouchet's test, the Salquaxi test, KD test, and the Keller-Kilani test. So on free time, you can just look at those tests for the glycosides. The other ones are the mechanism of action of the digoxin, and it has been explained here. Then side effects. I'm seeing there's an image here with side effects. So the side effects on this image are unusual tiredness or fatigue, anxiety, and hallucination. In case of poisoning and toxicity, we will see visual disturbances, nausea or vomiting, arrhythmias, electrolyte imbalances, which the poisoning and toxicity can be worsened by other medication. Just as an add-on, that the digoxin is derived from the foxglove plant. It's used to treat atrial fibrillation, atrial flutter, congestive heart failure mechanism. We've looked at it. Yeah, contraindication, as said before, the ventricular fibrillations are a contraindication. Anyone else with something to add on cardiac glycosides or digoxin? As we've been discussing also the pharmacology of digoxin. So perhaps just something to add on digoxin is the decreased levels of potassium, that is high patient to digoxin toxicity. So hypokalemia predisposes a patient to digoxin toxicity because digoxin will compete with potassium for the same binding site on the sodium potassium ATPase. So if you have a low potassium level, that means digoxin has no competition, it binds more, hence it increases the chances of toxicity. So hypokalemia increases the chances of toxicity of digoxin. So drugs, especially the loop diuretics, which can cause hypokalemia, you wanna watch out when you're co-administering it with the digoxin. Felicia, the PK of digoxin. I pick the pharmacokinetics of digoxin.
Excuse me.
Yeah, go ahead.
I thought the correct answer was C, as was read out by someone, because it is contraindicated in arrhythmias. It will worsen the arrhythmias.
So now in that case, you see arrhythmias is kind of general because we see it has a use in atrial fibrillation, which is a type of arrhythmia. Yeah, but for constrictive pericarditis, in Medscape, Medscape it's listed as one of the major contraindications for digoxin in Medscape, according to Medscape.
Okay.
Yeah, hence the answer A.
Okay, thank you.
Then,
Excuse me. Under the notes I read, in fact, the only contraindication that was in that literature was the cardiac arrhythmias for digoxin. They have not specified. Okay, here it has been, but I think cardiac glycosides, digoxin is one of them, and the main contraindication of digoxin is cardiac arrhythmias.
Yes.
Or maybe we can research further and we will come back to it later. Meanwhile, we can be taking that constrictive pericarditis.
So let's research further on contraindication of cardiac glycosides as a general contraindications of cardiac glycosides. Yeah, then someone is requesting that we go through the pharmacokinetics of digoxin. Perhaps all I know is that it's eliminated through the renal route. So in case of renal dysfunction, you need to adjust the dose. I don't know if anyone can add anything regarding the pharmacokinetics of digoxin.
The elimination of digoxin is proportional to the dose, to the total dose. It follows the first order kinetics. That's what I can add.
Nice. First order kinetics or first order elimination.
And again, after intravenous administration to healthy subjects, 50 to 70% of the dose is measured excreted as unchanged digoxin in urine. Approximately 25 to 28% of digoxin is eliminated outside of the kidney. Like 25 to 28% is eliminated outside of the kidney, maybe through other means.
Okay, great. Yeah. Then I think one last thing is, what is the antidote for digoxin toxicity? The specific antidote. Well, someone is saying B is saying that digoxin is indicated in atrial fibrillation, but contraindicated in ventricular fibrillation. Munira saying the Digibind, which is the common brand name of the digoxin antibodies. Yeah, that's correct. And also I'm seeing Ali has shared something that cardiac glycosides are contraindicated in conditions in which there is obstruction to ventricular outflow. For example, hypertrophic obstructive cardiomyopathy, constrictive pericarditis, and cardiac tamponade. Acute myocarditis may also increase the risk of toxicity. Yeah. So that is on the contraindications of cardiac glycoside. We are seeing the hypertrophic obstructive cardiomyopathy, constrictive pericarditis, cardiac tamponade. Yeah, so contraindications. And also we can add, of course, ventricular fibrillation onto the list. Believe we can proceed. We've extensively looked at the pharmacology of the digoxin, and also the test for the cardiac glycoside has been sent to the group, and just have a look at it. Yeah. And also there's for digoxin, someone is added that there's a need for therapeutic drug monitoring. As we said, it's a drug with a narrow therapeutic index. It can easily be toxic within no time. So moving on to number 148, I believe we've exhausted.
Did you talk about anything for antidote?
Yeah, we say the specific antidote we are having the digitoxin antibody, digoxin antibodies, or Digibind, as it's commonly known as.
Okay, thank you.
Yeah. So number 148, the question asks, if you have any further addition on digoxin on cardiac glycoside, just share it on the chat box, or just feel free to unmute. Yeah, any contribution matters. So the synthesis of DNA can be inhibited by ciprofloxacin, carbenicillin, ceftazidime, or gentamicin. Who says ciprofloxacin is the answer? Ciprofloxacin is a bactericidal antibiotic belonging to the fluoroquinolone class, which inhibits DNA replication by inhibiting bacterial DNA topoisomerase and DNA gyrase. So ciprofloxacin, among the choices listed, is the one that inhibits DNA synthesis. I believe we looked at the beta-lactams yesterday and also the aminoglycosides, so we don't need to dwell much on the other choices at this juncture. Perhaps with fluoroquinolones, any burning addition, perhaps a side effect that you want to tell us about, a drug-drug interaction that is unique in fluoroquinolones? But what I know is that fluoroquinolones, when you co-administer fluoroquinolones with NSAIDs, it lowers the seizure threshold. So in a patient with a history of seizures, you don't want to co-administer a fluoroquinolone and an NSAID. Remember, NSAIDs are drugs that are just over the counter and easily be taken. Then tendon rupture is a unique side effect, and also is Hans has mentioned the risk of seizures. Yeah, tendon rupture and the risk of seizures. So you don't want to give them to kids, right? To guys below the age of 12, or some references say below 16, some others say it's below 18, and we also don't want to give them to the elderly. It's that risk of tendon rupture, right? And it's also for it's teratogenic, so also contraindicated in pregnancy. Moving on to number 149.
I think there's also something to do with you should not administer fluoroquinolones with antacid. Yeah, the aluminum and magnesium containing antacid.
Because they will form that complex. Yeah, perfect. Yeah, so you shouldn't co-administer the fluoroquinolones with the antacids, because they'll form that a complex similar to the situation we were seeing with the tetracyclines, right? Something has been shared on the group on the uses of fluoroquinolone. We have the ophthalmic infections, infections of bone, soft tissues, respiratory infections, TB, UTIs, adverse effects, tendon rupture, should not be given to children below 18 years. Pregnancy category C, they cause seizure, they have that risk of seizures, they prolong the QT interval, dizziness, confusion, and photosensitivity mechanism as said. Perfect. The routes, oral and IV, beautiful. Because we have the even ophthalmic, the drops, the ciprofloxacin eye drops and such things. Mystique is also telling us to avoid milk within 2 hours of administration. You know, give that window 2 hours before, 4 hours after, something like that. Don't tell the patient not to drink milk for the whole week. Yeah. Then number 149 now. Just keep them coming in. I'll keep reading them out. Mnemonic for antibiotics that inhibit protein synthesis, which is malt, right? And M macrolides, A aminoglycosides, T tetracycline, L is what? Lincosamides. I'm guessing. You're the one in a position. Yes. So macrolides, aminoglycosides, lincosamides. In the lincosamides, there's majorly clindamycin. And the tetracyclines, we looked at the tetracyclines, Jana. Yeah. Dr. Koech has also shared her TikTok video on the discussion on fluoroquinolones. Right. Perfect. Moving on to number 149, very swiftly. Inhalation of corticosteroids can cause oropharyngeal infection with. So once you inhale these corticosteroids, we can see some oropharyngeal infection, which is the most implicated pathogen. Dr. Ral is telling us that Candida albicans is the most implicated pathogen on the same. We've previously looked at both oral and esophageal candidiasis, and we won't spend much time there. I think now in this case, it's advice to patients, especially patients using the inhaled corticosteroid, asthmatic patients majorly, is after they've done the puff, they rinse their mouth, right? So as to wash out the corticosteroids, avoid this oropharyngeal infection.
Number 149, 150, and 151. Didn't we do this, Amma?
Yeah, now these ones we did. Now we don't know if it's a repetition, so in another paper, which will give us hope that we've done all the past papers, or it's the same paper again. I think though it's a repetition from a previous past paper. So most effective for motion sickness, we did and said the hyoscine. 151, we say the most effective is Cipro. So we won't repeat the same. Elevated aminotransferases. I think we've also done these lugosiodine, hydrochlorothiazide. Yeah, we've done this. Petite. Yeah, we've done this. We've done this. Yeah, and we also did those pharmaceutical calculations. Covered that. Just pause the record. So the question asks, the following naturally occurring diazines are pyrimidine bases except. The following naturally occurring diazines are pyrimidine bases except. Dr. Linda shared something very nice yesterday, and we know adenine is a purine. All the others are pyrimidines. So don't need to dwell much there. We have done a similar question. Number 2, which among the following has a hydrogen halide with the longest hydrogen halogen bond and the weakest bond strength? So which among the following compounds has a hydrogen halide with the longest hydrogen halide, hydrogen halogen bond and the weakest bond strength? This is hydrogen bromide, hydrogen chloride, hydrogen fluoride, or hydrogen iodide. So my 2 cents would be hydrogen iodide because it's the least electronegative among the listed options. Yeah, everyone is changing choice D, hydrogen iodide. For Hiral, the reason does it have to do with the electronegativity?
Yeah, the electronegativity, and also because iodine has it's bigger compared to the rest.
Great, thank you.
So you have the longer, it's like bigger like bond.
Nice. Thank you for that. Perhaps just quickly, someone can tell us the trends among the halogens. As you go down the group, what happens to the atomic radius, ionic radius, electronegativity, such things, reactivity? And I think in the same line, we haven't looked at trends across the periodic table. We can just mention them briefly. Atomic radius across the row across the row, down the group, those things. If someone has a nice summary on that. Trends of the periodic table, majorly atomic radius, ionic radius, electronegativity, stuff like that. Our chemistry gurus, the likes of Dr. Nugal, Dr. Koech, Dr. Sam. Trends in the periodic table.
I think for the atomic radius, across the group, the radius will decrease, while going down the groups, the radius will increase.
So down the group, the radius will increase. Across, it will decrease. Could you give us the reason?
Across the group, we are having an increase in electrons in the same energy level, while in the nucleus you have an increase of protons. Hence, somebody has answered in the group. in the chat box.
Use your words. Use your words. So,
Okay.
yeah.
No, just read their words.
Okay, okay. So someone is saying electron affinity, electronegativity, fast ionization energy, all increase across the period and decrease down the group. So electron affinity, electronegativity, and fast ionization energy, they will all increase across the period, but decrease down the group, okay? Then also I'll just read out this image that has been sent that also highlights those strengths, that atomic radius will decrease. I'll start with just across the period. So atomic radius will decrease. Ionic radius, of course, will also decrease. Electron affinity will increase. Ionization energy as shared will increase, and electronegativity will increase. That is across the period. We have the atomic radius and the ionic radius decreasing, electron affinity, ionization energy, and electronegativity increase. Then now down the group, we are having the atomic radius and ionic radius increasing. Then all the others, electron affinity, ionization energy, and electronegativity, we'll see them decreasing. So it's the opposite of what you see happening across the period. Someone else adding that the metallic character increases down the group and decreases across the period, okay? The metallic character increases down the group, but it decreases across the period. The metallic character increases down the group, but decreases across the period. Perfect. So those are the periodic table, the trends of the periodic table. Right. Moving on, unless someone has something to add, we'll move on to question number 3.
Something to
Go ahead.
also the shielding effect. So across the period, the shielding effect increases. Yeah, and also down the group it will increase. So shielding is just now because of the outer electrons. Oh, sorry. Across the period, shielding does not increase, but down the group it increases because there's more energy levels.
So across the period, you do not see the shielding effect increasing, but down the group, we see the shielding effect increasing as a result of this a new cloud or an additional cloud of electrons or shell of electrons. So moving on swiftly, question number 3 asks, all of the following components will give only one major product upon reaction with hydrogen bromide, except. All of the following compounds will give only one major product upon reaction with hydrogen bromide, except. So all will give one major product, but one. Which one is it? All of the following will give one major product upon reaction with hydrogen bromide, except. My organic chemistry people, Dr. Sonia, you know, I'll always mention you. Anytime the word organic chemistry is brought around, I'll always say. Dr. Lydia is saying choice D, that choice D is the answer. Are we all in agreement?
Why choice?
And I'm saying comfort for saying perhaps if Dr. Lydia, if you're in a position to unmute and offer just an explanation, we'd really appreciate why choice D, why not the other choices? Just what was the thinking behind choice D? Or comfort also, why choice A?
And I think it's choice A because it's alkane. Like the others have double bonds, so you can see the double bond will break. One electron will bond with hydrogen, the other with bromine, like that. But then A is just an alkane as it is. I'm not seeing any double bond there, so how will it react? That's my logic.
For choice D, I'm saying another person supporting choice D, they're saying choice D will form 50% will be ortho and 50% will be meta. 50 will be ortho, 50 will be meta.
So the reason why I chose choice D is because if you break the bond, the hydrogen, the bromine can either go at, let us start counting from where the CH3 is as position 1. So our double bond will be at position 2. So the bromine can either be replaced at position 2 or position 3. So meaning we'll have two products. Yeah, I can see someone saying it will follow the Markovnikov addition reaction. That's what I was thinking. So meaning we'll have two products. We can either have it at either position 1 or position, either the bromine can either be replaced at position 2 or position 3. Meaning we can either have, that is 2 bromo or 3 bromo. Thank you.
Thank you for that, yeah. So we can have either 2 bromo or 3 bromo, yeah.
Excuse me.
The
Markovnikov is for choice A, not choice D.
The Markovnikov is for choice
A, not D.
So choice.
Wait.
Yeah.
Wait, someone explain here that double bond in A is, because if you're saying that dash there after the methyl, then it would mean that cell group is bonded to 3 hydrogens, then it's bonded twice to the carbon, so meaning it would have 5 bonds, not 4, unless it was a mistake, but I don't understand what
the double bond is in the other end, not the end that has CH3, the other end, where we have CH, then CH2. That's where we have the double bond.
Oh, okay.
Nice. So comfort, are we rallying behind choice D?
Yeah, it's D.
Thank you for that. Then briefly, we're having a request. If someone can explain Markovnikov and anti-Markovnikov. We are saying all of these Russian names, but we are not saying what these Russian names mean. So Dr. Hasna, Markovnikov versus anti-Markovnikov.
I'll send it to the group so you can just proceed.
But now they want an explanation so that it will help them understand the photo. Or anyone, Dr. Iral, I think you've explained Markovnikov and anti-Markovnikov before. If you can just explain it again.
So it's usually involving elimination reactions. So Markovnikov is when the halogen will be placed in a more substituted area, while anti-Markovnikov is where the halogen is in a less substituted position. Does that make sense?
I think Markovnikov for addition reaction.
Can I just explain?
if we have, for example, the hydrogen bromide, then the hydrogen will move to the carbon with more hydrogens. Now that's Markovnikov. If it's anti-Markovnikov, then the hydrogen will move to the carbon with the less hydrogen. Yeah.
Sorry, it's an addition, not elimination. Sorry.
Yes,
nice.
can I just add more on the explanation using an example of the what we have? So under B, under Markovnikov rule, the halide, that is bromine, will add to the number 1 where the CH3 is attached in our addition. So we'll only have one product under B, because the bromide can only add at carbon number 1 where CH3 is attached. And when you come to same to C, so we can only add bromine to the ring. That is C. So where to the ring where we have, okay, I don't know how, where the double bond is, the hydrogen will be added to CH3. Okay, hydrogen will be added to CH2 and bromine will be added to the ring. So we'll have bromine where we have the, I can't really explain it, but I hope you're getting what I'm trying to say. So when you come to choice A, let me just try to draw the structure so that I can explain using the structure.
I'm sharing a whiteboard. Maybe you can draw on that. Can you guys see?
Yeah, you can see your whiteboard. So meanwhile, the Markovnikov versus anti-Markovnikov. So the hydrogen will go where hydrogen is many, the bromine or the chloride or the halogen will go where hydrogen is few. That's Markovnikov. Anti-Markovnikov is the opposite. Yeah. So perhaps after this, Hiral, you can just mention again now based on that image, which can really help. Yeah, you say how many hydrogens are at that position. Yeah. As Lydia, can you draw? Lydia, are you in a position to draw on the shared whiteboard? Perhaps she's drawing on a piece of paper, then she would send the image. Meanwhile, Shina, I think we can be continuing because I'm seeing no activity on the whiteboard yet. Can continue with the past paper.
Hello, I'm really sorry. I'm not able to draw on the whiteboard. Maybe I can just write down and I will share on the group.
That works. That works. Thank you. Thank you.
I'm really sorry for that. Okay. I'll just write and then share it on the group.
Then let me see who it was. Person requesting the Markovnikov and anti-Markovnikov addition reaction. Are you satisfied? Yes, they are good. Okay, so we can proceed on to the next question. Which asks, which one of the following compound has a chirality center or chiral center or chirality center, depending on who taught you. So which of the following compound has that chirality or stereo center?
Nasikia kusema nini?
Which of the following compounds has a chiral center among choice A, choice B, choice C, or choice D?
B.
Sunshine is saying choice A. Dr. Schumer is also saying choice A. And Chu is saying that for choice A, it has ethane on one side, hydrogen on the other side, hydroxyl group on the other side, and a methyl group on the other side, making it have four different, making it a stereo center, four different attached to that one carbon. So about the chirality or stereogenic center, remember we will denote it as R or S. We had covered it in a previous discussion. R if it's going clockwise, S if it's going counterclockwise. Yeah. Moving on to number 5, unless someone has something to add on that or is not agreeing with the choice A. Stanley is adding that glycine is the only amino acid which has no chiral carbon. Glycine is the only amino acid with no asymmetric carbon. Glycine is the only amino acid with no asymmetric carbon. Thank you for that. Thank you for that. Moving on to number 5, the question asks on the correct numbering system for purine. How do we number purine? Where do we say it's carbon number 1, 2, 3, 4, 5, 6, 7, 8, 9? How do we number purines? We've really said adenine and guanine are purines, but we haven't mentioned the numbering of purines. So based on the choices provided, which one is the correct numbering of purines? Dr. Thomas has already shared something on the group and depicting that carbon number 1 will be on the pyrimidine ring. So 1, 2, 3, 4, 5, 6. So you fully number the pyrimidine ring first. after which you go to the imidazole ring now, 7, 8, 9. So you fully number the pyrimidine ring, then you go to the imidazole ring. Yeah, thank you for that. Thank you for that, Dr. Really, it's helpful. Yeah, so you fully number the pyrimidine ring, then you proceed on to the imidazole ring. So based on that, I think 1, 2, 3, 4, 5, 6, 7, 8, 9. So choice A, right? I think choice A is what? Choice A would be the correct one. I don't know, can't see well. Choice C. Choice C. Okay, choice C. 1, 2, 3, 4, 5, 6. So someone says choice D. Okay, I'm zooming my screen so that I can see well. Oh, patients, no, not choice D. Also choice C. 1, 2, yeah. Sawa sawa. Tuko pamoja. Yeah, choice C. Yeah, choice C. Yeah. Now I'm seeing. Yeah, choice C. Yeah. So moving on. Dr. Anita is asking, why not A? Why not A?
The NH gets the last number.
The NH gets the last number. The NH will get position number 9. The NH will get position number 9. Thank
you. Guys, what time are we doing till?
1 p.m. They said 1 p.m.
Oh, okay.
Yeah. So number 6. Though I'm seeing as if number 6 will be covered, but watch I will see as we go. Which of the following compounds will be relatively, what is relatively the strongest as an acid? Ethane, ethyne, ethane. I think from methane you can just say it's out. So ethane, ethyne, ethane. Between alkane, alkene, and alkyne of the same length, which one which one has more acidity between ethane, ethyne, or ethene? Personally, I go with the ethyne, the alkyne. They are most acidic in terms of the alkane, alkene, alkyne. So the same length, the alkyne will be the strongest acid. On question number 6, anyone with something to add or to contribute on question number 6? I know organic chemistry is a torturous area. I'm being told to kindly explain. I honestly have no explanation. I just know alkynes will have the strongest acidity based on the reactivity. Let me, something I recall is that for an acid to be strong, an acid is only as strong as its conjugate base. An acid is only as strong as its conjugate base. So for the conjugate base of the alkyne, the triple bond stabilizes it more. The triple bond will help in the stabilization of the conjugate base of an alkyne as compared to alkene, as compared to alkane. That's why an alkene will be a stronger acid than alkane, because the double bond will help to stabilize the conjugate base. Yeah, I may. Anita, please go ahead. I think I'm spreading rumors. organic chemistry, I shouldn't be talking. To share that from Google saying that alkynes are more electronegative, hence the hydrogen atoms can therefore be liberated as protons more readily in the ethyl. Then also, as shared on the group, something on the about the Markovnikov addition, right? About the Markovnikov addition as explained. Moving on to number 7. The question asks which of the following compounds has a pKa value of approximately 10. Which of the following compounds has a pKa value of approximately 10? The following compounds has a pKa of approximately 10. Acetic acid, ethanol, phenol, or water. Having people tweeting that phenol has a pKa of approximately 10. Phenol has a pKa of approximately 10. So for number 7, phenol it is. Perhaps on the same as the person was writing on the question paper, if someone can find a diagram with this, with the various functional groups and their approximate pKa values or their grading based on acidity or alkalinity, to really help our future discussions. Yeah. So if someone can find the various functional groups and their unique acidity or alkalinity properties. So moving on to number 8. If you have anything to add, please feel free to unmute and contribute, or write on the chat box, or even share on the WhatsApp group. What you've shared will be read out. So number 8, which one of the following alkanes will produce only one alkyl halide product upon monochlorination? Which one of the following alkanes will produce only one alkyl halide product upon monochlorination? Upon monochlorination. Answer as choice C. Yeah, because and see choice C there, it's like it's a symmetric compound, like, yeah. Choice C. Are we all in agreement? Number 8, that that compound, that alkane, will only produce one alkyl halide as upon monochlorination. So just an addition to the previous question, that the higher the pKa value, the weaker the acid. Nice. So the correlation between pKa and acidity. The higher the pKa, the weaker the acid. So it's like pH and pKa, right? When we say the lower the pH, that means the stronger the acid. The lower the pKa also, the stronger the acid. The higher the pH, the weaker the acid. The higher the pKa, also the weaker the acid. Thank you for that addition. So number 8, choice C. Let me see, I'm seeing something on the WhatsApp group. Perfect. Someone has sent the what? The pKa's of the various functional groups. So starting at the weakest of the weak, we are having the alkanes, followed by alkenes. This is the order of acidity. Alkane is the weakest, followed by alkene, then alkyne, then the ketones, the alcohols, the phenols, carboxylic acid, and at the very top we have our very potent HCl. So at the bottom of the barrel, we are having alkanes, alkenes, alkynes. At the top, let's say we disregard HCl because we are looking at the organic functional groups. We'll have carboxylic acid coming in as number 1, phenol coming in at number 2, and alcohols coming in at number 3. Then when it comes to the basic properties, of course, it will be vice versa, right? The alkanes, we'll see them giving off the stronger base, and the carboxylic acid will give off the weaker base. Yeah. Thank you for that. That really helps.
Can I add something?
Yeah. Go ahead.
A strong, I don't know if it was said, but a strong acid gives a weak conjugate base. So if it's a strong acid, it will give a weak base. So if you see from the table you have been reading, it's actually the reverse. You find that HCl, which is a stronger acid, gives a weaker base, a weaker conjugate base. Yes.
Perfect. So a strong acid gives off a weak conjugate base. It can't be strong in both worlds. If it's a strong acid, it will give a weak conjugate base. So if you just catch the order in one way, in case of an exam, you can just reverse it and get the. So for number 8, someone is asking why choice C? Why choice C? Perhaps, Hans, if you're in a position to unmute and explain why choice C, why not the other choices? Or anyone who's also in agreement with that.
Symmetry. You know, if maybe hi.
You're really breaking.
Okay. Am I clear now?
Yeah, you're clear now. Go ahead.
Okay. Because of symmetry, all the others, if you look at them, monosubstitution will happen at either or. And when you're naming them, you're supposed to give the position halide the lowest value possible. Now, if you consider C and I monosubstitute it at either the first or the last carbon from either side, the compound remains the same, unlike A, B, or D.
Perfect. So simply it comes down to symmetry, right? That wherever the knee will go, it will remain the same. The compound will be essentially the same, but in the others they are not symmetrical, hence, yeah. So moving on to number 9. A dash, when reacted with nitrous acid, produces N-nitrosamine. A dash, when reacted with nitrous acid, produces N-nitrosamine. So is it a primary alkyl amine, a primary aryl amine, a tertiary amine, or a secondary amine? When reacted with nitrous acid, produces N-nitrosamine. It's a secondary amine, a tertiary amine, a primary aryl amine, or a primary alkyl amine. When reacted with nitrous acid, produces N-nitrosamine. Produces N-nitrosamine.
Secondary amine.
A secondary amine. So secondary amine, when reacted with nitrous acid, produces N-nitrosamine. I guess this is those types of questions. If you know, you know. There is no explanation. But James is saying that primary amine plus sodium nitrite plus HCl would give a diazonium salt. A primary amine plus sodium nitrite plus HCl would give a diazonium salt. Nice. It's thank you for the addition, Dr. Eric. Thank you. Moving on to number 10. Yes, number 10, the question asks, which one of the following class of compounds generally undergo a bimolecular nucleophilic substitution reaction? A bimolecular nucleophilic substitution reaction, an SN2 reaction. Which one of the following class of compound generally undergoes a bimolecular nucleophilic substitution reaction? Is it the phenols, the alkyl halides, the alkanes, or the ethers?
Alkyl halides.
Alkyl halides. Great. The alkyl halides will undergo that bimolecular nucleophilic substitution reaction. Is there anyone with something to add on that, on this type of reactions, or can tell us what would undergo the unimolecular nucleophilic substitution reaction?
I know of a bimolecular nucleophilic substrate reaction. The rate of the reaction is dependent on the concentration of both the substrate and the nucleophile. Like the higher the concentration the substrate, the higher the nucleophile that will be formed.
Nice. Thank you. Thank you. So it depends on both the substrate and the nucleophile. The rate of the reaction depends on both the substrate and the nucleophile.
An addition, the
and then for
bimolecular.
The S1 is the opposite. The S1, the rate is dependent only on the concentration of the substrates.
Great. Thank you for that. S1, SN1 only substrate, SN2 both substrate and nucleophile. Then someone else also had something to add on the same.
An addition, the bimolecular nucleophilic substitution, there's always the inversion of stereochemistry.
There's always the
inversion. The inversion of us, because it's just a one-step reaction. So the, I don't know, the reagent or whatever is coming has to attack from the back. It has to attack from the back. So there'll be inversion of stereochemistry.
Perfect. Yeah. So the bimolecular SN2, we are saying there will be a version of the stereochemistry from R to S or from S to R, yeah. Then also someone has shared something on the group, just read it up. The differences between SN1 and SN2. SN1 is a unimolecular, SN2 bimolecular. So, that's the first difference, that one is uni, two is bimolecular. Second difference is that SN1 is a first order kinetic reaction. As we are told, it just depends on the substrate, while SN2 is a second order kinetic reaction. It depends on both the substrate and the nucleus. The rate of the reaction, it's what we've already alluded to. SN1, the reaction proceeds in 2 steps. SN2, as we've been told, it's a 1 step. Okay? So, of course, in SN1, since the reaction proceeds in 2 steps, we'll be having a carbocation intermediate being formed. But in SN2, there's a transition phase mediated reaction. Finally, the last difference is that in SN1, if optically active substrate is involved, racemization will occur. However, for SN2, if optically active substrates is involved, inversion of compound will occur. Yeah, inversion of compound will occur. So those are the differences between the SN1 and the SN2 reactions. Same with also something else sent by yeah. So you can see that every version, the bromine, I think when it was in a wedge, and now the new group, the OH, has been on a dash. Bromine was on a wedge, but this other one, OH, the hydroxyl group, has come in, it's in a dash. I think wedge meant Kombele, dash meant Newman. Chemistry, man. It's a beautiful subject. Anything else on the chat box? See anything? So, alkyl halides is the answer. Moving on to question number 11. Moving on to question number 11. Always, even if we've passed a question and you have something to add, just add it on the chat box and mute, send it on the WhatsApp group.
Let me just add something on the SN2 reaction. When you see like it usually occurs with strong bases, something like sodium hydroxide, in this case alkyl halide, maybe like HCl, they usually undergo the SN2 reaction because we don't need to form the carbocation intermediate. So for the strong bases, if you see any reaction involving a strong base, just know it's an SN2 reaction.
Yeah. Thank you. So SN2, strong bases. If you see a strong base, don't think twice. It's SN2. Great. So number 11, the term chemical shift. The term chemical shift is commonly encountered in which type of analytical method? Is it in mass spec, X-ray, crystallography, NMR, or IR? Mass spec. I think there was a time we would have had this discussion, but we weren't well informed. I'm seeing now everyone knows it's NMR, right? Chemical shift. Does someone just want to give us, again, just a quick overview of these analytical methods of analysis? We are seeing that at least we should expect 1 or 2 questions on analytical methods of analysis. The 3 major ones, mass specs, NMR, or IR. Anything you may know on that? Even this chemical shift, what does it mean? Mm-hmm. Are you talking, Ama? It's by mistake. Oh, it was by mistake. Anyone who can tell us something about mass spec, something about NMR, something about IR, anything you may know? Okay. Then if you get something on the same, I know we'll send them on the WhatsApp group to, yeah, so we can proceed. Substitution. So number 12, ATP production takes place in which intracellular organelle? The mitochondria. We looked at the cell organelles before in so much detail. We don't need to again spend a lot of time there. Number 13, which of the following listed reagents may be used as a quantitative test for alpha amino acids? Which one's going to be used for amino acids? Generally, for amino acids, we have the ninhydrin, right? That they use to detect your fingerprints. Then for the other solutions or the other reagents, who can tell us what they are used to detect what class of compounds or what types of compounds? Vanillin, Dragendorf, Felins. They're used to detect what type of compounds?
Dragendorf, I think it's alkaloids. It forms, is it yellow or orange color with alkaloids? I think it's orange, not yellow.
Okay, so Dragendorf alkaloids forms an orange color. Okay. Vanillin, Felins, what are they used to detect?
Vanillin is just a molecule. It's not a test.
It's not used in the detection of steroids.
Vanillin is one of the aromatic compounds.
Someone is saying is used in tannins to detect tannins.
It is used to detect steroids.
Steroids. So not tannins. It's felins for the reducing sugars. Okay. So vanillin, steroids. We Hans perhaps can tell us, is it tannins? You're the one who said tannins. Dr. Hasna is saying vanillin aldehyde also. Dr. Patient has added that for the detection of the anthraquinone glycosides, we use the Bontrager's reagent, Bontrager's test, Bontrager's reagent. Yeah. So on vanillin, kindly let's confirm it's used in pharmacognosy, because I'm seeing a lot of different answers. You can just confirm, send on the WhatsApp group. It might have been sent, no, not yet. Okay. So moving on to the next question. And also you can add the other reagents used to detect the other types of compounds, especially pharmacognosy, the alkaloids, the steroids, the tannins, all of those, the glycosides. So number 14, the question asks, most protein structures are stabilized by all of the following weak bonds except. Most protein structures are stabilized by all of the following weak bonds except hydrophobic, disulfide, hydrogen, or electrostatic. Disulfide bond. Oxygen is for hydrophobic bonds. But now I ask the question, is disulfide a weak bond?
No, it's not a weak bond.
Hopkin, tuko pamoja, ama you're still for the hydrophobic bond? Perhaps you can explain or inform us why you'd go for the hydrophobic bond. We can highlight the disulfide bond. Move on to the next question, which asks which statement is false in regards to enzyme? Which statement is false in regards to enzymes? Enzymes are protein catalysts for biochemical reactions. Measurement of enzyme activity is used in disease diagnosis. Enzymes are reaction-specific catalysts. Enzymes catalyze several similar biochemical reactions. So based on our discussion on enzymology, which one of the following is false? So each enzyme catalyzes several similar biochemical reactions. That's the best answer among the choices. Oh, the answer, sorry. That's it. Yeah. So enzymology we've discussed before, and the types of inhibitions, characteristics, properties of enzymes we've covered before. We won't dwell so much. Then again, this is something related to enzyme. Which vitamin is not an essential constituent of coenzymes? Which vitamin is not an essential constituent of coenzyme? Choice A, B, and C, all of those are vitamin Bs. Then choice D is a vitamin C. So ascorbic acid, do we see ascorbic? We know the vitamin Bs are the ones which majorly are involved in being coenzymes to our enzymes, yeah. And again, we need to repeat this. Remember those names for the vitamin Bs. It's something that has been tested before. It can be tested again. Thiamine, B1, B2, riboflavin, B3, niacin, I think B5, pantothenic, B6, pyridoxine, B9, folate, B12, cyanocobalamin. I think Dr. Stanley had sent something on the group describing all of those names. Number 17, the question asks, which of the following is not an end product of amino acid metabolism? So which one is not an end product of amino acid metabolism? Is it cholesterol, urea, carbon dioxide, or ketone bodies? which one is not an end product of amino acid metabolism? Think cholesterol, right? Because amino acid metabolism, we know, due to that production of ammonia group, it will send stuff to the urea cycle. The urea cycle will begin with carbon dioxide somewhere, and also through the transamination. I think there's something to do with ketoglutarate with a ketone body, something like that. So me, I'd go with cholesterol. Anyone else? Then in the same, while we're on this topic, or while we're on this question, someone can just give us an overview of amino acid metabolism. We've looked at glycolysis in detail, TCA in detail, but amino acid metabolism with just a brief overview on amino acid metabolism. What happens to our proteins once we swallow them and they are absorbed as amino acids? Anyone with a brief overview, or even if you have a nice image that can summarize amino acid metabolism, you can send it on the WhatsApp group or here on the chat box, and we can have a look at it. Amino acid metabolism. Amino acid metabolism. I remember here we can't afford to be silent hapa kwa biochemistry. Chemistry ni sawa, kwa tulinyeshewa. Biochemistry, we have to compensate. We have to compensate. Nice, I'm seeing something beautiful on amino acid metabolism has been sent on the chat box to also be shared on the WhatsApp group. But once your intracellular proteins or your dietary proteins, at the end of the day, they will give us the amino acids. And we know from the amino acids, we have the carbon skeleton and the amino group. The amino group can go towards the biosynthesis of other amino acids and biological amines, and or it can go into the urea cycle to be detoxified as urea. We know ammonia is toxic, urea is not toxic, urea is eliminated in the urine. Then the carbon skeleton, where we are forming our alpha keto acids, these ones can enter into the TCA cycle, the citric acid cycle, lead to this production of oxaloacetate. From oxaloacetate, we can synthesize glucose through gluconeogenesis, and we can see also how the urea cycle and the citric acid cycle can be or have this connection through the aspartate arginine-succinate shunt of citric acid cycle, connecting the two pathways. At this juncture, I'll just remind us of the mnemonic, the TCA mnemonic. It was citrate is Krebs starting substrate for making oxaloacetate. Let me just write it on the chat box. Citrate is Krebs starting substrate for making oxaloacetate. So that will correspond to citrate, citrate followed by isocitrate, followed by the now keto. Is it keto something? Krebs 13. We have the succinyl CoA. Succinate. Yeah, so that's mnemonic for the TCS cycles, how the products will flow from one compound to the other compound, from one compound onto the next, onto the next. So moving on to number 18. Unless someone has something, let me check the WhatsApp. Okay. So amino acid metabolism, just have a look at it